Welcome everyone. I am D'Souza and I am a researcher at Thompson River University. Today we have a knowledge translation cancer care network consortium and we will have a few guest speakers, keynote speakers and plenary speaker. In our research grant, one of the main things we were looking and studying was the cancer survivors and people who are diagnosed with cancer and treated. How is their journey been with cancer support care and psychosocial care and even educational care. So some of the outcomes, recommendations and policy is brought together as a knowledge translation, and through this we are advocating for interdisciplinary approaches and psychosocial oncology with the work that we are doing. Today we have with us Michelle Smith, and she has been a co-investigator in the research grant and working with us to continue the work with knowledge translation. So welcome, Michelle Smith.
Thank you.
And you'd like to introduce yourself here?
Hello, I'm Michelle Smith, a regional practice lead for research quality and knowledge translation in the research department at Interior Health, and also adjunct with the Faculty of Social Health and Social Development at UBC Okanagan.
So Michelle, thank you very much for introducing yourself, and it's so relevant with your work in the research practice and education and your own work that you're doing with the research grant that is now with people who are living with cancer and also with people who are seniors. So how do you see this participatory action research and intersectionality lens in the grant working with the cancer patients and also with family members?
So I think specifically with this project, it was based in the community, and participatory action research, we mean that it came from the people in the community and their experiences, and it was driven by what they saw. And so with Malba's project, I found it was invaluable to the people in the community that had cancer. So community-oriented participatory action research was the focus of this project. And what was so important about that was that the community drove the project, and as well the all-inclusivity of the stakeholders, decision makers, universities, like this came to connect about what was important and how to make a change with what was needed for cancer survivors post-treatment. So what supports they need in the community, because there often is a gap between treatment and what happens after. And so what this project highlighted was where the needs were and what we could come together to talk about to improve how the quality is and what was needed for everybody. Another important aspect of this project was the intersectionality approach that really moved from what the community was saying was important to them and where the gaps were and where they saw need and what was working and what wasn't working, was the lens of looking at the experience of the people and bringing that back to the group and discussing how to move forward with that. So looking at the perspective of other people and applying it to how we make the change, and including how you apply evidence-based practices and changes to improve the policies and procedures that come out of that as well. And that's incredibly important because often policies and procedures are they don't necessarily change unless you approach it with some evidence-based research that says, look, there's a gap here, this is continuing healthcare, it's quality of life throughout pre-cancer treatment, cancer treatment and beyond, and that's incredibly important just as much as the treatment piece itself.
So what do you think are the policy strategic directives that came out from the study that lean towards interdisciplinary approaches in psychosocial oncology and its influence with working with people who are living with cancer, their caregivers and care partners?
I think one of the things we find is that there tends to be one GP or one cancer doctor that they see, and there's no continuation, to connect that person and their care provider or their family member that's helping them with other support systems. And if there's no right now, there's no policy in place for that. It's treatment, and then you're off, and then the rest of it depends on what the community supports are, and there's no policy about how to follow through with cancer survivors through their community and supporting them through their next steps, and including, does it end or is there remission and does it come back? Mm-hmm. And how do they navigate that? Mm-hmm. And I think policies in place that can talk about recognizing that quality of life is as important as the care treatment itself, because it's intertwined. It's not one or the other. I find, like, working in the health authority areas with the healthcare system, that if it's not highlighted in a policy or procedure, it's not possible to, like, manage that piece. It has to be recognized as something that has to be done, and it has to be outlined in a policy or procedure, or it's not part of the process. And then, and with this type of research, you're actually asking them what happens after you leave this part and you go back to the community. Melba, what help do you envision in interdisciplinary approaches in psychosocial oncology?
Thank you, Michelle. This is a very good question. I think one of the main aspects that came out from the research study was communication with healthcare providers and research participants. And the second was about funding issues with different aspects related to travel, accommodation, stay, with medications and treatment aspects. And the after treatment was the major part where people have to get back to their life, especially return to work and with their own quality of life, getting back, normalizing their life into things that they usually do and getting that rhythm back into their life. So with these two things, I think one of the main aspect that came up was to create a cancer innovation and synergy lab that we have with working with research participants. And the second was an online educational hub for people and for navigators where they can get resources and supports through their cancer journey, and also for the navigator to help and support people and empower them in their journey.
Thank you, yes. And it's the geography of an interior health region is incredible across the rest of BC, so just the ability to know what to do from where you're at.
Yes.
And know how to find it.
Yes, like with funding issues, the main thing was for the people, the access and the use of the cancer care resources and support within their own community, especially if they were in a remote area or even in a rural area. Example, like living in Revelstoke, or living even in Barrier, Clearwater, Williams Lake. So being able to access the support they need in cancer care and also to navigate their own cancer care journey, and also being able to help and support themselves after the treatment. So the resources they need to reach out to, the kind of things that change in their life because of what cancer and the treatment has been on them, has been a huge impact on their own quality of life, on their own economic impact, and also about being able to facilitate their journey in cancer.
It's impactful because I think, like, it's not recognized often that the people's lives in those areas, and then seasonally,
yes,
the winter, the snow passes,
yes,
people don't expect to be ill, and they're trying to do everything when they're not feeling well already, and their quality of life and having to seek help for themselves is very challenging. The harsh environments all over the place.
True. That was the main focus of our research study. It was looking at mainly the barriers that people face and the facilitators, especially with healthcare services, with complementary and alternative therapies, with their own economic and social supports, and also with their own family and their own activities of daily living, and also looking at psychosocial dimensions. So that was the major aspects that people, what they find available and being able to access. And this leans on to also some aspect of it has when they access cancer treatment and diagnostics, where they need to travel and how they need to access the resources in their own community. It also brings to understanding some of the psychosocial oncology pieces as to how the healthcare provider or the nurse provides this support to the person when they meet them for the first time in an environment, maybe in the clinic or in a hospital place or even in the community when they transition and go back to the community. So how telehealth and telephone helplines, even community resources, even the webinars that are placed out for psychosocial education, and how that can help a person returning to life and being able to living with cancer and still continuing to work and being part of society and the community they belong to. So Michelle, thank you very much for giving us a lens into intersectionality and participatory action. So I do understand that this research participants are from all over the interior region and also from British Columbia. So what is your, when you look at policy implications and recommendations for seniors' health and wellness with cancer care and with the knowledge translation, how do you see that as happening or something that we need to look at and talk about?
And how the perspective from the participants saw as well in amongst that, like reflecting on what they're saying, is that having an interest or like a wide group of support. So they have their full communication of a multidisciplinary or interdisciplinary team that can follow them through each step, because it's not just, the weight of one physician to try to manage all those pieces of their care, but be able to like have care plans and work in a way that is a comprehensive care plan that they can have pieces and everyone knows how they're supporting that person, including their, if they hopefully have a family member or someone that can actually provide extra support for them. And then the other thing is, and I think this comes up a lot, is how to share the education or the knowledge translation piece. Like, how do people access that information? Because some people, like, depending on age or exposure or what they're comfortable with or how they want to view things, visually or orally or whatever, but just multiple ways to access, and also various languages. Like BC is in all different parts, is growing more with more different languages that we need to be able to respond to and have the proper communication and materials that they can access, and up-to-date, relevant information that reflects current research about what's the best practices to do. And have that at every step of the way, and have ways that they can access, printed materials in the clinic, mailed to them, emailed to them. Like, there's a variety of ways to do it, and I think there's never one perfect way. I think in other discussions as well, there's always so many ways that people prefer different means of accessing that, but more in readability, like not giant sheets of reading. I think that's part of knowledge translation.
I think that's an important part also for decision support when they're looking at how they're making decisions, informed decisions with their care aspect. Like when they're choosing the kind of diagnostics and even the treatment part of it, it plays a role. And even after treatment, the kind of decisions they go with for the different aspects that come with the activities of living or return to work, decisions with how they want or priorities they want to change with taking care of themselves or even with their family members. So how do you see that people are using these decision support tools or applications available in the community or with the healthcare services?
Yeah, how to be able to access those. And that's complicated unless it's kind of through the same system. There's a continuum of care and system of how that can happen. But the information for that physician that they're dealing with, it helps. The physician that they're seeing for their treatment as well, if they can have that in their back pocket to be able to share with that patient or their family member to help move forward with what else that they can do. Because I think also it's, they're seeing people as they can, and they don't have access to it. And I find other things. I found in this and other projects as well, when you're trying to share information, is that it has to be really fast and easy for them to share. They're not going to seek it out. Like, you can give people all kinds of doctors or anyone links. They can read and access the links, but they don't have time to it needs to be simple and straightforward and something they can pass along quickly and make it comfortable for that patient, to that person and their family to be able to access that. Because sometimes I think it's a bit, in and out, and they just don't want to ask. Like, I think almost they don't feel comfortable asking for support, but a system like a navigator or the website or different ways people can access information is more comfortable to people sometimes as well. So you're not always just relying on the one person to share all that information, I think.
I think you brought up a very important point about sharing information and resources. At the same time, like an educational hub for them, or even a repository where these resources can be accessed, and also about a professional navigator to empower them and help and support them on their journey. So when you look at this navigator's role and also about people on their own journey, what implications it has for psychosocial oncology and how has interdisciplinary approaches, we approach people with how they take care with their own life after cancer treatment.
Yeah, and different aspects from different people, social workers, nursing, all the different community organizations. So everyone has a different view and comes with a different experience or discipline or they come from when they're training, or they've had cancer themselves, or their family members had cancer themselves. So they have that perspective, because I think when you're coming in brand new, you don't know, you're sick and you don't know what to expect. And I think the best people to have is somebody that has experience and also can also rally the other people together to help you know who to seek for what. Like, where'd you get the hair pieces that are, like, I've heard are way too expensive.
Yes.
And not covered, just on the side, things like that. And then how do they know, like, I have a family member that's kind of just has breast cancer that's just come back, and they live even farther north than we do, and they're traveling to get to everything, and just, there's no communication when it separates across communities as well.
Yeah.
So the materials and education that recognizes that's transferable to other communities, or at least there's understanding what community they're from and where their main treatment center might be, and things like that. So there's a long way to go, and I think when we try to even arrange in-person things with anybody to, like, for treatments or meetings, like the geography is just, we have to sometimes surpass. How do we surpass that? I guess is the question we always have to, which is online supports and education and people, and also people, if they're doing that, how do they, if it's a volunteer person and they're a community person, they have all this experience, but they're doing it for free, like that, how often can that go for? Like, they need to be able to, like, fund or support services like that, because especially in the rural and remote communities, there's not enough people, and you're going to rely on one person that may or may not be there, or they may have other things, that family and work they need to do. So just a lot of, how do we support that and put that in policy, procedures, processes in place that it doesn't stop at the door of the treatment, and then everyone's left to figure it out on themselves, and then people are providing free service to support. So that's the other, like, often that's the case with the community support groups and everything.
Yeah, I hear what you're saying, because even from the research study, the kind of decision support people take is based on the access and the use of the healthcare and the community resources they have. So one of the choice that they make is with choosing maybe treatments or cancer treatments based on where they are living and how much they need to travel and who's at home. So even sometimes it's about the side effects of the treatment that they have and what are they navigating in life at that point, with maybe the time they are placed at, maybe in work or in education, or being a family member taking care of their family. So that influences their choice of selecting the kind of treatment they need, and also about their quality of life. So most often from the research participants' view, it is about their own longevity and also about their work productivity and what kind of work they return to and how are they going to continue. So that could be some of the important priorities they have in making decisions about what treatment they choose. And even after treatment, returning to work or returning to their normal life, it's also about making that decision support as to what's important for their quality of life or even for their own health and well-being. So what are the things that change in their life, or what becomes priority now, and what are recommendations they take from maybe their own healthcare provider whom they are seeking care as continuity. But if you think about some of the research participants and having an unattached healthcare provider, that makes a lot more different for them as to where is their care being navigated, or how are their care being documented, and how there is continuity of care. So I think there are important learnings from shared by the research participants, which translate into knowledge as to what implications we have for an interdisciplinary approach with psychosocial oncology, and also creating this cancer care innovation and support for people through maybe psychosocial oncological education resources, and also for having an educational hub where people can access the resource. So I think from your view, there's also something that important that we gather today is about the kind of nature that people have in their own life, that what is priority to them. Like when you talk of intersectionality, here's once again a person's identity, their own cultural, their own language, their own way of seeking, like you said, very, very efficient way, like fact documents, and also readability of those documents, and being able to use it in life. Like where would they hear the first time about this? It could be with their healthcare provider, listening to this information and facts, but maybe being able to register that information and being able to seek out what's my goal, or what action I need to take, or commitment to my own action in making decisions. What's the best decision for me to do now, or who I need to reach out at the time when I'm feeling, example, when the research participants, some of them voiced about the anxiety, depression, stress, unable to sleep. And sometimes it's about physical aspects, like when they voiced out about the pain, the fatigue, the nausea, vomiting, constipation, or diarrhea. So it can be this multitude of myriad physical, psychosocial problems which may again lead to feeling of isolation and loneliness, and hence an important part again navigating them with interdisciplinary approaches in psychosocial oncology and being able to see that in healthcare and also in the community they have. So it could be a local where they are living in rural and remote. It also be maybe an urban setting and suburb area where they're able to access. And most of that with COVID has changed, like most of the access has been virtually situated with telehealth, and also with mobile clinics going to their mobile vans and also seeking to get telephone calls with their healthcare provider and arranging that. So thank you very much, Michelle, for your insights and perspective. I think it's a lifelong journey in this research work that we do together, and also looking at what's the best way we can support people with interdisciplinary approaches in psychosocial oncology. So thank you so much. Michelle, you did mention about participatory action research, and the research question coming from the community here about their own experience, perception, and practices with cancer care. Also, can you just talk about when you mentioned you had a research team, community partnership and healthcare partnership and collaborators on the grant. How did this add a lens of intersectionality to the work from the beginning, from the time that you have looked at what is the experience, perception and practices of people, to looking at maybe what are the psychosocial dimensions, and right now where you are looking at cancer navigation and support, how does this intersectionality play a role with your research study?
I think what was really important and impactful, which is impactful about this study, I believe, is that the intersectionality piece, the lens that was applied, is everyone has various values, beliefs. They come from different backgrounds. They live in different areas, and as do we. And so as we look, and as do all the staff and community and healthcare providers. So recognizing that everyone's coming from a different place, which is different than almost that you see with general health care, where everyone's the same, it's just everyone's a person and we all apply it this way. But when you look at where people are coming from, what their experiences are, recognizing them and asking what those are, then you actually have a more impactful and more rich information to actually make a change, because you've actually asked the people and you're looking at it in a way that you're being inclusive of all the different values and experiences people have and perspectives that people have, and recognizing that they are different, and also that having that lens of how do we do this appropriately, the cultural appropriateness of how we're looking and being respectful and recognizing all the different ways to look at the study and what the perspectives of people are, and then how do we apply that in a way that we can provide the best supports for them and the community they're at and their family.
Yeah, I can hear your voice saying, speaking about the voices of the people here, their perspectives. And also when you're adding that dimension of including them, like a social inclusion and social justice for people from different streams and walks of life who are continuing with cancer care and in their continuing journey. And I'm also hearing that piece where you're talking about equity-oriented healthcare. And that's the most important lens, I think, when you think about an equity-oriented healthcare service and system that delivers the healthcare service, especially with cancer care, to people who are maybe from pre-screening to diagnosis, treatment. And also when they survive and their longevity, recurrence and prevention of recurrence, there's a whole lot with the standards of care, with the standards of practice, with the policies that come with it. And also when you talked about important part of cultural playing a role, and even linguistic psychosocial support to people, it adds so much value to the care that healthcare providers today in our British Columbia system provide to people, and also from their own perspectives of how an important role each healthcare provider, a physician, a nurse, a psychosocial person, a social worker, a physiotherapist, a masseur, and all these people together from multidisciplines and interdisciplinary areas, and even research team members play a role in looking at how we can bridge the gap and how we can take cancer care initiatives to the next level of providing innovation and synergy and partnership between the different resources and services we have within British Columbia, and also looking at cross-border, like our provinces, where the best of practices with cancer care navigation and support is, and learning from those practices and how it adds lens to our own psychosocial oncology care reaching out to people. So thank you so much for that lens.